All right, so we're going to be starting chapter 8, which is all about skin disorders. We'll start with a little bit of an introduction or a little review of some of the skin anatomy. We'll talk about the most common skin lesions. We'll describe the inflammatory skin disorders. Then we'll move to some skin disorders that are related to infections. And then we'll talk about some of the major skin cancers. So let's just review the layers of the skin, which includes the epidermis, the dermis, and the subcutaneous. Um, Remember, the epidermis is epithelium, it is avascular. The dermis is composed of connective tissue. There's muscle tissue there, and there's neurological tissue. It's also vascular. And then we'll show you the subcutaneous, or the subq, also known as the hypodermis. So when you look at the top portion on the left here, you'll see the epidermis, which has those 5 stratum layers. And then deep to that, we have the dermis, and then deep to that is the subcutaneous. You'll see blood vessels in the dermis as well as the hypodermis, but there is no blood vessels up in that upper layer. Um, in the dermis, you'll also see part of the hair shaft. You'll see the erector pili, right? When this contracts, it makes the hair stand on end, which gives people goosebumps. There are sensory receptors here. We have sweat glands. We have sebaceous glands or oil glands. Remember, the sebaceous gland produces these oils that move up the shaft and then creates this watertight seal right here that makes the skin water resistant. Some say the skin is waterproof, but I really think water resistance is better than waterproof, because waterproof means that water can't escape or that you can't absorb it. We know that that's not true. You can lose water through the skin and you can absorb water from the skin. So I think water resistant is probably the best term. And the oils that are secreted create this like antibacterial um, formulation that has a lot of antimicrobial and bacterial properties to it. When the hair shaft moves, it does stimulate a lot of nerve fibers. Okay, so you can tell if like an insect is walking on you and so forth. All right, and then down at the bottom we have adipose and fat cells. This is where a lot of the subcutaneous injections do take place, down into the hypodermis area. A lot of the lesions or scratches may happen up here in the epidermis, um, in which case you won't see bleeding, right? But if it goes deep enough and ulcers down into the lower portion where the dermis is, that's why you can bleed, because the capillaries and blood vessels here are affected. So some lesions you will see as we discuss them stay up here in the epidermis. Some lesions do go down into the dermis, and some even into the subcutaneous. Okay. There are 5 layers, right? Remember all those stratum layers. There are some cells that were the most common protein in cell is keratin, and we know that the whole top layer here where that stratum corneum is just dead cells that slough off. And it takes about 4 weeks or so from the cells all the way at the bottom at that stratum basal layer, or that stratum germinativum, where you have these stem cells. They multiply and divide, and they push the layers up to the top, where you have 25 to 30 layers of dead cells called the stratum corneum that slough off. In some disorders, that pace can be accelerated, and it could take 4 to 7 days for it to reach to the top and slough off. Melanin is the black substance, right? It's the mela, black, the black substance. It is what gives each of us a little bit of a different skin tone. Some could be very pale, some could be olive complexion, some could be extremely, extremely dark. So we all produce a similar amount of melanin. I'm sorry, we all have around the same number of melanocytes, but how much melanin each of us produce is a little bit different, and that's what gives us all different um, skin tones. If you have a issue where you have missing melanocytes in specific parts of your skin, then you're going to have lighter areas or hypopigmentation. They call that vitiligo. If you have an inherited um, decrease of tyrosinase, and tyrosinase is the enzyme that helps us produce melanin. There's a little bit of a typo here. It shouldn't say lack of melatonin, right? Melatonin and melanin are not the same thing. So let's make sure that we change albino or albinism to the lack of melanin and not melatonin. Okay, but that is primarily a result of tyrosinase. So here, the individual, all of their skin is going to appear very, very white. Okay, if you remember seeing the movie, it's an older movie. It's got to be over 20 or 25 years old, I would think, called Powder. Very, very intense and interesting movie, but the young gentleman was albino. And then if you have areas of patches of darker skin instead of lighter skin, that's melasma. In the dermis, there's connective tissue. The connective tissue is made up of elastin and collagen. These fibers can be destroyed by excessive UV radiation. Collagen fibers can be destroyed from the chemicals and smoke. And this is what gives people the lack of skin tone or the wrinkling that's associated with smoking and even excessive sun exposure, which will affect the flexibility and the strength of the skin, and you get wrinkles. The dermis contains nerves, blood vessels. The nerves are sensory receptors for pressure, touch, pain, heat, and cold. There's also the hair follicle that we showed you in the dermis. Associated with the hair follicle is the smooth muscle, the erector pili muscle. And then we showed you earlier the oil gland, which is the sebaceous gland that produces sebum. There is the secretion of sebum, or these oils, tend to increase at the time of puberty due to the influence of the sex hormones during that time. Then we have sweat glands, which are referred to as sudiferous glands. You even have them in the axilla. The secretions there tend to be a little bit thicker, as they are around the external genitalia. And because it's in an area that's not completely breathable, it's dark, it's moist, there's a lot of bacteria that can grow there. And when the bacteria give off their exhaust or their gases, that's when it could give people body odor in the axilla. And then beneath the dermis is the hypodermis, or the subcutaneous, where also we have connective tissue because there's adipocytes and adipose or fat cells. We have macrophages, which is part of our immune system, fibroblasts. The blood vessels are a little bit larger there, and then we have nerve endings as well. Okay. So that's just a little bit of review. Again, we have the epidermis on top, then the dermis, then the hypodermis. You can see the blood vessels are in all the layers with the exception of the epidermis, and most of the accessory structures do lie in the dermis, whether it's the sweat gland, the sudiferous gland, the oil gland or sebaceous gland, the hair follicle, the erector pili, all the blood vessels. The primary function of the skin, remember, it's our first line of defense. It prevents excessive fluid loss. There you go. So instead of waterproof, it's water resistant. And then it controls body temperature, We know that our sweat pores and sweat glands can open, and we can cool off by sweating. It's involved with sensory perception, pain, touch, deep pressure, light touch, hot, cold. And the skin is involved with the synthesis of vitamin D, which is really a hormone, right? So you have the UV light coming down, hitting the subcutaneous on the skin, the subcutaneous cholesterol on the skin, and that subcutaneous cholesterol creates some of these vitamin D precursors that go to the liver, and then those precursors become hydroxylated again after the liver at the level of the kidneys, where we make cholecalciferol. Vitamin D is so important not just for the immune system, but they have found vitamin D receptors on just about every organ in the body. There are so many different diseases that are associated with vitamin D and vitamin D deficiency, especially when it comes to skin disorders. We'll see that a lot with psoriasis being linked to vitamin D deficiencies. People have to be real careful, especially in the Northeast. We don't get direct sun exposure from mid-September to about mid-May, right? From mid-May to early September, we do get sun exposure. So that tells us that we really need to get our vitamin D levels checked at least twice a year in the winter and autumn months, in which case most of us do need some degree of vitamin D3 supplementation, and then again in the spring and summer, where perhaps if we were supplementing and then we're spending time outside, the vitamin D supplementation can come down. Whenever vitamin D is being supplemented, it should always be with vitamin K at the same time within the formulation, because vitamin D does allow you to absorb calcium into your blood vessels, but we do want to prevent vascular calcification. When blood vessels harden and they lose their elasticity, blood pressure goes up. It's the vitamin K that assists the calcium in the blood vessels and helps to drive it into the bone. Okay, that uses matrix GLA protein. Matrix GLA protein is involved, and that's vitamin K dependent. So whenever using vitamin D, should always be associated with vitamin K within that formulation. Okay. The skin does have a natural flora that's associated with it. It has a variety of them. So we have to be real careful not to destroy them, because it has to be in balance, just like the microbiome in the gut has to be in a specific balance. There are also microbes that can hide right under the fingernails. You have to be careful all day when you're touching things. Be careful not to, stick a finger with a nail, that may have microbes under it into a nasal cavity. That may not be the smartest thing, because there's really not much distance between the upper nasal cavity and the brain. All you have is that cribriform plate, and don't forget, through that cribriform plate, which is the ethmoid bone, you have the olfactory bulbs. So there's a direct connection from the nose directly into the brain, and nerves are a highway of communication of bacteria and viruses that can spread into the brain. There are opportunistic infections that may occur because of the injury or other inflammatory lesions, and we have to be careful because infections can spread systemically from skin lesions. All right, so that's a little introduction. Let's look at some skin lesions. So the physical appearance of the lesion is necessary in order to make a diagnosis, and the specialists that deal with skin are referred to as dermatologists. They are an extremely important part of the healthcare team. Skin lesions may be caused by systemic disorders, infections, allergies, and even localized factors. So there are systemic disorders that can create skin lesions, like vascular disorders and liver diseases. They can show up in the skin. Infections, whether it's herpes or chickenpox or bacterial and fungal infections. Allergies can manifest, whether it's seasonal or food allergies or sensitivities or allergies to certain drugs also show up through the skin. And localized factors as well, including exposure to toxins. The type of lesions, we have to consider their location, where they are, the length of time that the lesion has been there, and occurring over time. We have to also consider the changes of the physical appearance and how long it takes for those changes to occur. We have to look at the color. We have to look, are they elevated? Palpation, what is the texture? How does it feel? What type of exudate? Is it clear? Is it pussy? Is there the presence of itching, which is pruritus? Is it painful? Let's take a look at some of these names of some of these skin lesions, because these are important to be able to know and identify. So when you see a small, flat, circumscribed lesion that's a different color than the normal color of the skin, it can be brown, it can be blue, red, or it can even be hypopigmented. It could be a lighter color than the skin. We refer to that as a macule. So on this side, we have hypopigmentation, macule, and on this side of the skin, it's hyperpigmented. Those are macules. A papule, we can see now it's small, it's firm, looks like it's in the epidermis here, and it's an elevated lesion. That is a papule. A nodule is a firm raised lesion, but this one extends a little bit deeper than a papule. This one looks like it's invaded into the outside of the epidermis, into the deeper part of the epidermis, right? Here, this is kind of in the epidermis, and it kind of blisters upward, right? But if we look, it doesn't go into the deeper layers of the epidermis like any of those stratum layers. But if we look here, we can see not only does it elevate and go upward, but it also permeates a little bit deeper into the stratum layers, okay? Not necessarily into the dermis, but to the deeper stratum layers. That's a nodule. A pustule, this is elevated. It's erythematous, which means it looks like erythrocyte, so it's reddish, right? It's raised, often has a little bit of a head. It can have some pus or exudate that comes out of it, and that's an important feature. So it could be red, and it has a purulent exudate. That is a pustule, right? Looks like a little white head that forms here, and you have the redness, the erythema, around the periphery of it. A vesicle is, you can see it's looks like it's a blister. It's got a thin wall, it's raised, but this one has clear fluid associated with that. That is a vessel. So there are going to be many lesions that you'll see have vesicles in it. Here's a vesicle, right? Looks like little blisters. We'll see this type of appearance with herpes up around the lip, okay? Then we have crust. This is a dry, rough surface, and it's was at one point exudate. Could be a little blood that's just dried up, so we refer to that as crust. This is crusting here around the nose. Plaque, this is where you can see that there's slightly an elevated lesion. It's a flat surface here on top, but it's very scaly. It's a very scaly-like lesion. We'll see this primarily, these plaques, with psoriasis. And the word psoriasis comes from the Greek word pisati, which means fish or scaly, right? So this is plaques. You'll see this quite a bit with psoriasis. We'll go into psoriasis in a little bit more detail shortly. Now, erosion, this is not a result of the lesion growing outward. This is like invasion. It's almost like an ulceration, right? Erosion is this cavity. It's a shallow, moist cavity, but it's contained here in the top layer of the epidermis, right? It hasn't invaded into the vascular section of the dermis. This is erosion up on top, epidermis. You can see it's red, but there's no blood. It's not bleeding, because then that would tell us we're in the dermis now. We could see bleeding with an ulcer, right? This is when there's this cavity with loss of tissue from the epidermis down into the dermis. And as a result, we can have bleeding with this. This is common with bed sores. If someone is lying down in the bed and you got the elbows that are constantly irritating on the bed and they're not really moving for a while, we call them decubital ulcers. Cubital, like the cubital fossa, the elbows. Here's an ulcer. Here's a fissure, right? A fissure is a small, deep, but it's a linear crack or a tear that's in the skin. People sometimes get these on the underneath surface of their feet near the heels, right? We could see them here. These are fissures. Lichenification, this is thickening of the skin. The skin is dry, it's very rough. It's seen with a lot of chronic inflammatory issues. It could be seen with anxiety or obsessive compulsive disorder, where people are touching the same area of the skin over and over and over, irritating it. You can see lichenification with those issues as well. Pruritus, we've done this several times. It's that feeling of itchiness, but where do we see this? It's associated with allergies, with an allergic response. It's seen with chemical irritation that's caused by insect bites, right? People get stung by mosquitoes and it gets very itchy. Or mild irritation just from other chemical irritants. The infestation of parasites such as scabies, we'll go over scabies shortly in today's lecture as well. The itchiness is typically result from the release of histamine in a hypersensitivity response that's causing the pruritus. An infection may result from breaking the skin barrier, and that is caused by excessively scratching it over and over and over. The diagnostic test for skin lesions, cultures, and staining of the specimen is very important. For bacterial infections, they'll use a microscope and just directly observe it. There are specific procedures for fungi or fungal and parasitic infections. Biopsy is very important for the detection of malignant changes. Years ago, I remember I had a patient on my exam table, and while she was supine, I noticed she had a lesion on her skin on her right upper cheek near the zygomatic bone. And I pointed it out to her, and she said, "Oh yes, I'm aware. I'm going to the dermatologist at the end of the week." And I guess it was about a week or 2 weeks later, she came back and she had a bandage on her cheek, and she's like, "Doc, you gotta see this. This is crazy. Look at this." And she took the bandage off, and I saw how much of a biopsy they did. They went through a lot of tissue, like a core, just deep, to remove that. And I said, "Keep that covered." I mean, that was just super, super deep. So it had to have, penetrated or evaded some deeper tissues. And as they were biopsying it, they just kept, digging and digging to try and remove everything. So I will say several weeks passed after that, and she came back and she said, "Oh, Doc, it was benign." And I said, "That was benign? Oh my gosh, thank goodness. I should double check, just get a second opinion." I said, because they did take out a large core of that. And for them to say it's benign, and just double check it. And I never saw her again. I'm going to say about a year and a half, 2 years go by. I get a package in the mail. I open up the envelope. It's a pretty thick envelope. And it's an attorney that's requesting for my records. And I said, what is this about? And I'm looking, I go, who is this? And I saw the name and I remembered her and I said, oh gosh, I hope everything's okay. I hope she didn't get hurt. You know, accidents happen. And I'm scrolling through all the paperwork and I see a death certificate. And I'm like, oh my gosh. So I had also taken care of this woman's daughter many years ago. So I contacted the daughter and I said, I received this paperwork on your mom. What's going on? You know, they want my documentation. I'd be more than happy to supply them with anything they need. She said, I don't know if you remember, but many, many years ago, you know, she had light skin and she went to a dermatologist. They did this biopsy. And I go, oh my gosh. Oh my gosh. I said, I remember it very well. I remember your mother telling me, showing me, in fact. She showed me she went for the biopsy. She came back. She told me it was benign. And I said, I have in my notes here that I suggested that she go back for a second opinion. And she said, you have that in your notes? I say, I sure do. I said, I'll scan it and send it over to you. And she said, well, it was malignant. And in about 2 weeks after that, it metastasized into her brain. And she was dead. It killed her that quickly. So it was an error. It was a mistake at the lab. It's as simple as that. So it's something that should never have happened, but it did. So biopsy is done to detect malignant changes. Many people, when they get a test result, you know, and it comes back benign, they just let it be. But in that instance, it just didn't seem right to me. It just didn't make sense to see how much tissue was removed and to think that that was benign. Blood tests are also quite helpful in the diagnosis of conditions that are caused by allergies or abnormal immune reactions. They could check for different immunoglobulins. So if there's allergies, you're going to see a high amount of the IgE antibodies being produced. And then they do skin testing. They use patches or the scratch method and see if it reddens or inflames after that. So the general treatment measures for pruritus, they'll put a topical ointment on there to reduce the sensation. Sometimes they'll put a topical antihistamine or a corticosteroid topically. They'll just say, you know, let's try and stay away from and avoid the allergen. You know, reduce the risk of the reoccurrence for the itchiness. If it's an infection, then it's going to require an antibiotic. If it's a precancerous skin lesion, it's going to be surgery. Today they do lasers, which is just unbelievable work with lasers, electrodesiccation, and even cryosurgery. Cryo means cold or ice. Okay, we're going to continue with part 2 of this. You can pause there if you want, go through some of those key definitions. You know, you're going to be seeing those on the exam. If you feel like you want to go straight through, then here we go. Inflammatory skin disorders. There's something called contact dermatitis. Now, contact dermatitis is an acute or a chronic dermatitis that results from direct skin contact with either chemicals or allergens. And there's 2 types. There's an allergic contact dermatitis, and then there's an irritant contact dermatitis. The difference is one of these has an immune response and the other one doesn't. The allergic contact dermatitis is considered to be a type 4 hypersensitivity reaction, meaning that that one has an immune response. Here you can think of poison ivy or poison oak. Okay, so that is a allergic contact dermatitis. It can be sensitivity or an allergy to rubber, essential oils. There are even people who have allergies and reactions to Band-Aids or the adhesiveness that's associated or the stickiness of a bandage of some sort. But the key here is that with this allergic dermatitis, with the contact dermatitis, it's the cause of the type 4 hypersensitivity reaction. Okay, so there's an immune response. With the irritant contact dermatitis, it results in an inflammatory response, but there is no immune response. With the contact dermatitis, the allergic contact dermatitis, we could see small vesicles. They can be weepy, and they can crust. With the irritant contact dermatitis, the area is red, scaly, right? And in the area of the contact with the irritant, we're going to see itching and burning and stinging, and it can be pretty severe. So here on this illustration, on the left, we have the contact dermatitis, right? This is probably an issue or an allergy to the adhesiveness of the Band-Aid. And here is the irritant, right? This is here the irritant contact dermatitis, itchy, burning, stinging, and it can be pretty severe. That's this. Urticaria, which is hives, it's a result of a type 1 hypersensitivity. This is seen, again, with people who have ingested maybe shellfish. A lot of people are allergic to shellfish. And if they are, they have to be careful with certain supplements and vitamins that may contain remnants of this. People who are allergic to shellfish can't have a lot of arthritis supplementation or supplementation for their cartilage and painful joints like glucosamine, chondroitin sulfate. So we have to be careful with that. Certain drugs and certain fruits can create this as well. There's the release of histamine that causes the erythematous lesion, the redness that's on the skin. The lesions can be scattered all over the body. They're highly itchy or pruritic. And keep in mind that hives are often a part of the anaphylaxis reaction. I have known many people who have taken certain antibiotics, they end up getting hives to it or urticaria. It's certainly an indication that they are allergic to that medication. It's really important that if you see that, if you do see the hives, that you have to have the patient open up their mouth. You want to check for any swelling of the tongue because we don't want that swelling up or obstructing the airways, okay? This is where, if you do see that, then you have to administer an EpiPen, right? And first aid would definitely be required for that. So here's urticaria. These are hives. You can see them on the face and the neck and the upper chest commonly. Atopic dermatitis used to be referred to as eczema. So atopic means that there is an inherited tendency towards allergic conditions. So this is where family history comes into play. When you do a thorough case history, you're not only asking about their history, but you're also asking about their mother, their father, the grandparents on the maternal side, and the grandparents on the paternal side. Very, very important to do that. What will we see? Besides the family history that may include eczema, you'll ask any history of allergies or allergic rhinitis, hay fever, any family history of asthma. So very important to do an appropriate family history. Chronic inflammation can result from response to allergens. On blood tests, we'll see an increase in the eosinophil count, so we call that eosinophilia, and an increase in the immunoglobulin E's, the IgEs. This can be a common problem, atopic dermatitis in infancy, but it can also persist into adulthood. What are the clinical manifestations of atopic dermatitis in infants? Pruritus. It's just extremely itchy. The kids are always scratching themselves. It could be moist red, and then you see these vesicles, and when they scratch them and they start to ooze, then it starts to crust. Okay, we could see this on the face, the neck, the buttocks, and we see it a lot on the posterior side or the extensor side of the upper and the lower extremities. With adults, the lesions are dry and scaly, and it can thicken up. That's that lichenification that we showed you earlier, that we saw associated with people with OCDs as well. The treatment is obviously try and avoid the aggravating agent, and then topical glucocorticoids as well as the antihistamines. These are the common sites of the eczema. We see it here on the dorsal surface of the wrist. This looks like the crease, the elbow crease. And again, we see it on the knees and the dorsal surface, the top of the foot, and the leg. Pretty severe. Psoriasis. This is a chronic inflammatory skin disorder, and the onset usually happens somewhere in the teenage years, and this results from abnormal T cell activation. There's excessive proliferation of the keratinocytes, and the cellular proliferation is greatly increased with increased epidermal shedding. And it just excessively proliferates and sheds very, very quickly. You'll see the beginning with which would be like a red papule, which enlarges, and then you start to see the silvery plaques, the scaling of that starts to develop. It can, the plaques, if you continually scratch them and scrape them, then it will result in bleeding. You'll see this around the scalp, the elbows, the knees. It can itch. And you can also see some signs along the fingernails where they become pitted, thick and pitted. These are treated with glucocorticoids. Sometimes they'll use UV light and methotrexate, which is in the category of the anti-metabolites. These are some of the areas that you can see. Psoriasis, you can see it kind of looks like here. You can see it on the back of the arms and the elbows. You see it under the scalp, so people can hide these pretty well. If you wear long sleeve shirts, they can be hidden very well. And this is what the pits look like on the fingernails. It's certainly a very, very strong indication of what's called psoriatic nails. The P is silent in psoriatic. Okay, pemphigus. This is an autoimmune disorder whereby autoantibodies cause disruption of the epidermal cells and blisters start to develop. Pemphigus vulgaris is the most common form. It blisters in the oral cavity or in the scalp. The blisters can spread all over the face and the trunk, and the vesicles rupture when they become larger. And then the area will start to, after it oozes, then it crusts. Because it's autoimmune, they typically use immunosuppressants or the corticosteroids. You could see here the vesicles, and here it's starting to already crust over. Scleroderma. This is another autoimmune disorder. This one affects connective tissue. It can affect a lot of organs as well. It has a lot of systemic effects which can target the organ. And what happens in scleroderma is there's just increased collagen deposition all over the place. Collagen deposits, there's inflammation, there's fibrotic tissue that forms, there's decreased blood supply and capillary networks. The skin becomes very hard, it becomes tighter, it becomes shiny, the areas become a little bit stiff and difficult to move, tough to move the mouth and the eyes. And if we look at the clinical manifestations, we use the acronym CREST, C-R-E-S-T. C for calcinosis, R for Raynaud's that I spoke about in an earlier lecture. There are esophageal changes, sclerodactyly, and telangiectasis. So the C for the calcinosis, here the calcium deposits in the subcutaneous tissue, and that can cause pain. And it can also cause stiffness. The Raynaud's phenomenon, this is due to the vascular effects. There's going to be the arterial vasoconstriction. And we see this in response to cold weather and stress. Many people have to move to warmer climates as a result. There's esophageal changes where there's difficulty in swallowing. That's called dysphagia with a G. When you say the word dysphagia, it almost sounds like has an S sound. So dysphagia with an S is difficulty in speaking. Dysphagia with the G is difficulty in swallowing. Sclerodactyly, this is tightening of the skin over the fingers and the toes, and it leads to this very narrowed and tapered look of the digits and a little bit of atrophy. Telangiectasis, this one is where you have the dilation of the capillaries causing small red marks on the skin. Almost look like, maybe like spider veins, that type of appearance. So this is a typical appearance if you look at the tapering and the atrophy of the fingers. If you look at the tightening here, the sharpness, the sharp ridges of the nose, and the pulling of the upper lips, this is scleroderma. Here you can see the Raynaud's phenomenon. Typically, the fingers, they turn the color of the American flag, but just in a different order. They go white, blue, and then red. Okay, so this is in the early stage where it's white. You can see it on the fingernails as well. Okay, let's look at skin infections now. Now, the skin infections, this can be caused by bacteria, viruses, fungi, and parasites. Now you know why we covered these in the earlier lectures. Pathogens or opportunistic microbes can enter the skin from even the most minor cuts or abrasions, and then serious infections can develop. So let's look at acne vulgaris. This is a common skin infection in adolescence, pretty common in males, especially at puberty. The sebaceous gland and the hair follicle of the face, neck, and upper trunk become plugged, and then they become infected. And we can see something called comedones. These are commonly referred to as whiteheads or even blackheads. It's a non-inflammatory collection of sebum, sloughed epithelial cells, and bacteria. And then what happens is it clogs the gland and it prevents the appropriate drainage. So these are comedones, right? These look like blackheads right here. Acne vulgaris, there is inflammatory acne. This is where the hair follicle swells and it ruptures. There is bacteria called Propionibacterium acnes. This is part of the normal flora breakdown of sebum into irritating fatty acids. And as a result, inflammation is going to result. Staphylococcus organisms can invade, and that can create a pustule. And lesion ruptures causing local tissue destruction, and that can possibly spread. Skin damage and scarring are common as a result of this. So here's a illustration of that. Most people refer to that as acne. Furuncles. Furuncles are also referred to as boils, and this is caused by Staph aureus. It begins at the hair follicle. When you have an inflammation of the hair follicle, we call it folliculitis, and it spreads into the surrounding dermis. Commonly found in the face, the neck, and the back. It can begin as a firm, red, but a very painful nodule to touch, and it develops into an abscess. And the abscess can drain, and when it drains, a lot of purulent material can come out, and it can have a foul odor. When the person tries to squeeze the boil, and that can then spread to other areas of the skin, we call that auto-inoculation. Auto-inoculation. Squeezing boils can spread infection to other areas. A carbuncle is a collection of furuncles. That's a carbuncle. So here's a furuncle, and a collection of them are carbuncles. Cellulitis. This is an infection of the dermis and the sub-Q, and it's commonly caused by Staphylococcus aureus, occasionally strep. It is frequently found in people that have restricted circulation, commonly seen in the leg, and it's also found in immunocompromised individuals. The etiology of this could be a furuncle, a boil, could be injury, could also be an ulcer. Cellulitis, the area, is typically found in the lower trunk. Sometimes people get them on the upper part of they can find it in the lower part of the trunk, and most commonly in the legs. This is where I believe I shared the story about one of my patients who is diabetic and didn't know he was a diabetic, but I told you his lower leg was hot. You could literally fry an egg on it. The area becomes very, very red, very swollen, very painful, and then you can also see red streaks that may develop along the area of the lymph vessels. This is cellulitis. If you put the back of your hand to this leg, it would feel well over 100 degrees. Burning, burning hot. That's cellulitis. Impetigo. This is a common infection in infants and children. It can occur in adults. Again, the causative agent is Staph aureus. This one is highly contagious in neonates. In older kids, it's Staph aureus or a group A beta hemolytic strep. The infection is easily spread by direct contact or indirect contact through fomites, and you guys know what fomites are at this point. Impetigo, these lesions are commonly found on the face. They begin as these small vesicles. They enlarge and they rupture. They're yellow brownish, they call it honey colored, and then crust forms. And under the crust, the lesion is very red and moist, and it releases that honey-colored liquid. It often results with pruritus, and as a result, there'll be excessive scratching, and then you get that auto-inoculation where they can self-spread it to other parts of the body. The treatment is with antibiotics in the very early stages of it. Or the antibiotics have to be administered systemically if the lesion is extensive, not just topical. Here's impetigo. That's pretty severe. Acute necrotizing fasciitis. When you see that word necrosis or necrotizing, it doesn't look good. Okay, fascia is the clear, thin, translucent connective tissue that surrounds everything. Right? It's under the skin. It's superficial to muscle. It's around blood vessels, lymph, nerve. Fascia is really found through everywhere. So the acute necrotizing fasciitis is known as the flesh-eating disease. It can result in rapid destruction of tissue. It's the mixture of aerobic and anaerobic bacteria at the site of the infection. There's severe inflammation and tissue necrosis, and it's usually caused by a virulent strain of gram-positive group A beta hemolytic streptococcus. The bacteria secretes a toxin that breaks down the fascia and the connective tissue, and it just causes massive tissue destruction. But prior to that, there's usually a history of minor trauma or an infection in the skin and the subcutaneous tissue of that body part. But it's usually something minor. And then they're like, I couldn't believe it came from that. Could you believe? So the superficial fascia, the fascia surrounding skeletal muscle and all the other soft tissues, they become edematous, so they become very puffy and swollen, and then necrotic with occlusion of these small blood vessels, and eventually it can lead to gangrene. The area becomes inflamed, it's very painful, it just enlarges due to all the swelling, and then eventually leads to gangrene. in terms of systemic toxicity, have to look out for fever, tachycardia, hypotension, feeling of being disoriented or confused, and then organ failure. I mean, this could be deadly. A delay in treatment is a problem, right? There's going to be greater tissue loss because it's going to spread. It can lead to amputation, and then there's a high probability of mortality. So the treatment has to be aggressive antimicrobial therapy, constantly replacing with fluid and excision to just excise all of the infected tissue. And if needed, amputation to save the rest of the body so it doesn't spread throughout. This is an example of the acute necrotizing fasciitis, right? The flesh-eating bacteria going through. Just horrific. Herpes simplex type 1, right? So we're looking at some viral infections. It's the most common cause of the cold sore or the fever blisters and usually occurs near the lip. Herpes simplex type 2, this usually targets the genitalia, but type 1 is the most common that we see with the vesicles and blistering around the lip. The primary infection may be asymptomatic, and the virus can remain latent in the trigeminal nerve ganglia. If you remember cranial nerve 5, the trigeminal nerve has these three divisions: the ophthalmic division to the eye, the maxillary division to the upper jaw where the zygomatic bone is, and then the mandibular division. The recurrence may be triggered by infection, a common cold, sun exposure, and stress. Very, very commonly with stress. This is just a picture or illustration where you can see the herpes simplex virus that's going to enter the human, most likely through the oral cavity here or the lips. And then you see the virus will replicate inside the human cell, and it spreads to adjacent cells. So we see here the herpes simplex virus. It's invaded the cell, and it can spread to adjacent cells. Here we see the viral replication causes necrosis and the vesicle formation. Now, at times, the defense can actually control the infection, and the virus migrates along the trigeminal nerve to the sensory ganglia, and it just remains latent in the nerve. The lesion will heal, but it can also reoccur under stress if you have a cold, if your immune system becomes compromised, malnourished, poor sleep. Then it becomes activated again, and it migrates back along the nerve to the right back to the lip. It typically feels burny or tingly sensation. And here we go. So the clinical manifestation is burning and tingling along the nerve and the site of the lip. Then the painful vesicle starts to show. It ruptures and it starts to crust, and it can spread by direct contact with the fluid from the lesion. It can spread from others, possibly prior to the appearance of the lesion, right? So you could be asymptomatic and still spread this, right? There could be spontaneous healing in about 2 to 3 weeks. The viral particles may be present in the saliva weeks following the healing of the lesion, and this is when it could be spread to others, right? So you've healed up, and you can still spread it to others. There's no vesicles, there's no lesion, and this is the gift that keeps on giving, right? Have to be really careful with that. Herpes thrives on an amino acid called arginine, so a lot of people use L-lysine to compete with arginine. They flood their body with it the moment they feel the tingling or the burning, and then it typically cuts the time down into about a quarter of the time when they supplement with high dosage of L-lysine. And they put L-lysine usually in certain lip balm that they use to treat for herpes, and then they also make it in high concentration in capsules. What are some of the complications? You have to be careful with spreading it to the eye. That creates a condition called keratitis. There's another condition called herpetic whitlow. It's a painful infection of the finger. So imagine seeing what you have around the lips with the vesicles and the blistering down along the base of where the fingernail is and where the distal phalange is, and the distal interphalange joint. It just gets red, and you could see the vesicles that form there as well. You could see here, this is the vessels that are forming in herpes. Okay, verrucae or warts. These are benign lesions of the skin caused by many types of human papillomavirus or HPV. It can infect the stratus squamous epithelium of the skin and also target the mucous membranes. It is transmitted by touch. The verruca vulgaris is the common wart, and this is the one that often found in children. You could see it on the back of their hand, but it can really occur anywhere in the body. The appearance is usually a round, elevated growth. It could be rough. It's a little bit grayish. And you can see it here. It almost has a little bit of a cauliflower type of appearance. That's verrucae vulgaris. Fungal infections or mycoses. Most fungal infections are superficial. Why are they superficial? Because they live off of dead cells, and that's found in the keratinized cells of the stratum corneum. So it's diagnosed from skin scrapings. They can also be diagnosed from the fluorescence that takes place when exposed to UV light. It can be diagnosed from a microscope exam or as well as culturing it. Tinea capitis. This is a fungal infection that targets the scalp, common in young school-aged kids, and it can be transmitted by animals, especially cats or dogs, through Microsporum canis, and it can be transmitted by humans, Trichophytum tonsurans. Now, the appearance is that you'll start to see in kids these circular bald patches as the hair is broken off the scalp. So it's typically a sign of this fungal infection called tinea capitis. And the treatment is going to be oral antifungal medications, and this is what it typically looks like. Tinea corporis, infection can be scattered over the body, particularly of non-hairy parts. So you had this, tinea capitis, capitis, capital head, the scalp. Corporis, corp means body. These are found on the non-hairy parts. They're usually round lesions of vesicles or papules with a clear center. Sometimes the tinea corporis is referred to as ringworm. Also, for this one, typically topical antifungal medication works. We also see this in people typically say, I always get these lesions the same time each year. Every December or January, I start to get these. We often see it also with vitamin D deficiency, as many skin lesions are. So this is what the tinea corporis looks like. You can have them on the trunk, you can have them on the arm and the leg, and typically when they're on the arm and leg, they're much smaller. They could be about the size or shape of a dime and even smaller, but you have the periphery is usually a red raised lesion, rough raised lesion. Tinea pedis, if you look at this, ped like pedal, that's the feet. So this is at your typical athlete's foot that most people are common with. It's associated with swimming pools, gymnasiums. The fungi thrive in warm, moist areas. So you have to be real careful at the gym or at the pool. This is why having your own flip-flops, if you're using public showers, are always a good idea. Um, the feet can become involved. You'll look at them. I'll show you a picture. It can go in the hands as well, but most commonly the feet. They become itchy, pruritus. You can get these little fissures or cracks between the toes. And when that happens, then these secondary bacterial infections can occur. There is a lot of antifungal treatment that's used to treat this successfully. This is your typical athlete's foot. Okay, it looks dry. You can see these little fissures that form, and this could be problematic if it's not kept hygienic. So you have to be careful to sanitize and clean this properly when putting on the antifungals. Tinea unguum. This is another fungal infection. This typically affects the toenails. Okay, the toenails will appear thick, white. Can happen with people that have poor blood supply to the lower extremity. I see this a lot in diabetic patients and people who are obese or morbidly obese. They just tend to have a poor blood supply, and you can see the nail thickens. It turns like yellowish, thick yellow and green. You can see here it's thick, it's yellow. This is all fungus. Okay, some other infections. There's one called scabies, which is an invasion by mites, right? The female burrows into the upper layer, right, into the epidermis, and then lays eggs over a period of several weeks. And then the male dies after fertilizing the female. The female dies after laying the eggs. And then the larvae migrate to the skin surface, burrows into the skin, searching for nutrients. And this becomes very intensely itchy or pruritic. The larvae mature, and this entire cycle repeats itself. So this is what the mite looks like. And this is what it looks like, scabies in babies or infants. Pediculosis, this is lice. There's 3 different forms. One can attack the body, right? There's corporus. One can affect the head, capitis, and one can affect the pubic region, pubic louse. So you can see pediculus humanus is always in the beginning, and then corporus, capitis, or pubis for body, head, or pubic region. So this is lice. They're small brownish parasites, and they feed off of human blood. Here, the female lice lay eggs on the base of the hair shaft. The egg appears as a small whitish shell, and then after hatching, the louse bites the human host, and it's just feeding off of the blood. It sucks on the blood. The area of the bite becomes extremely itchy from the lice saliva. And then you get these excoriations, which result from scratching. And this is, you could see here in the hair, you could see the eggs right here. This is head louse. Okay, let's look at some skin tumors. Keratosis. This is benign lesions that are usually associated with aging or skin damage. There is seborrheic keratosis. So again, this is with age. It's the proliferation of basal cells. It leads to an oval elevation. It may be smooth, it may be rough, sometimes dark in color. It can be found on the face or in the upper trunk. So typically they call these age spots. Seborrheic keratosis. There is benign lesions that you usually associated with skin and aging. So then there's actinic keratosis. This is common on skin that's exposed to UV radiation. It's commonly found in the fair-skinned people. And the lesions appear hyperpigmented. It could be a scaly patch. And actinic keratosis can develop into squamous cell carcinomas. Here is actinic keratosis. This is on the scalp. What are the guidelines to reduce skin cancer? Reduce sun exposure at midday and early afternoon. Cover up with clothing, remain in the shade. Wear broad brimmed hats to protect the face and the neck, and apply sunscreen or sunblock. I try and tell my patients to be out in the sun for at least 15-20 minutes just for the vitamin D production, and then they could put on a sunscreen or cover up. But you don't want to completely block the UV rays from the healthy vitamin D production. Sometimes that creates more problems. So it's that proper balance based on family history and risk. Squamous cell carcinoma. This is a painless malignant tumor of the epidermis. The lesions are found on the areas that are most commonly exposed. But it can also happen in the mouth or the oral cavity. It can be on the face, the neck, and at the base of the tongue. It's scaly, it can be slightly elevated, it's reddish, it's got an irregular border and an ulcer in the center. The prognosis is pretty excellent with this when the lesion is removed pretty early on. So this is a squamous cell carcinoma. Basal cell carcinoma, this is the most common form of skin cancer. It's got a pearly papule, which develops a central ulcer known as a rodent ulcer. There's no pain with this, there's no itching with this, but over time, this can invade the subcutaneous tissue. So here, you could see that small little ulceration in the center. That's a basal cell carcinoma. It looks like this is the eye, the nose, so this is the upper cheek. Malignant melanomas, these are highly metastatic. It's a serious form of skin cancer. It arises from melanocytes in the basal layer in the epidermis. The nevi, or a mole, right? The nevi that grow, they can change shape, color, size, or texture, or they can bleed. If that happens, then you have to highly suspect a malignant melanoma because they're highly metastatic. The appearance, they're often multicolored with an irregular border. So when you see something that's multicolored and doesn't have a nice symmetrical round texture or surface and looks irregular, these are the ones that you have to be very suspicious of. They grow quickly. They invade in underlying tissues, and they metastasize quickly. And if they go to the lymph nodes, then we know, right? Lymph nodes or blood vessels, they can spread to other parts. The treatment is going to be surgical removal and radiation plus chemotherapy. There's something that we call the ABCDs of melanoma. So ABCD. Look at the appearance, look at the border, look at the color, look at the diameter. Is it elevated? A, B, C, D, E. So is it a change in the appearance? Is it a change in the border? Is it a change in color? Is there a change or increase in diameter, especially if it's greater than 6 millimeters? A pencil eraser is a good object to use as a reference because that pencil eraser is about 6 millimeters. And is there a change in the elevation? This is where dermatologists come into play, right? People look at their own bodies more than anyone else. So if you notice on yourself something that wasn't there or it was there but it changed, that's what you want to get evaluated and checked. And here is a malignant melanoma. It's multicolored, it's irregularly shaped. Kaposi's sarcoma. This was once a pretty rare cancer. Now it's seen a whole lot more than ever. It's associated with those with acquired immune deficiency syndrome and other immunodeficiencies. This can affect viscera and organs as well. These are malignant cells that arise from the endothelium in small vessels, and they look like purplish macules. They are not itchy, they're not pruritic, and they're not painful. It's found in immunocompromised patients. The lesions develop pretty rapidly over the upper body. The treatment for this is a combination of radiation, chemo, and surgery. This is Kaposi's, and there's the word sarcoma. You know what that refers to.